In December 2024, a man in a gray hoodie walked up behind a healthcare executive on a Manhattan sidewalk and shot him twice in the back. The victim was Brian Thompson, CEO of United Healthcare, the most powerful health insurance company in America. What happened next stunned everyone. Instead of shock and outrage at the murder, millions of Americans went online and celebrated. People were making memes. A 26-year-old named Luigi Mangione became a folk hero almost overnight, not because people approved of what he did, but because the shell casings found at the scene said it all. Investigators found 3 words written on the ammunition: deny, delay, depose. Those 3 words are what critics call the insurance industry's playbook for avoiding paying out claims. The reaction to Brian Thompson's death wasn't really about him. It was a pressure valve releasing after decades of quiet, building rage. Americans paying more for healthcare than any other country on earth, and getting less for it. Sicker, dying younger, and fighting insurance companies just to get the care they already paid for. And here's the thing, the numbers back up the anger. The United States spends nearly $15,000 per person per year on healthcare. That's 2 to 4 times what most other wealthy nations spend. And in return, the US ranks dead last in health outcomes among 10 comparable high-income countries. Last in life expectancy. Last in equity. Last in access to care. Americans die 4 years earlier on average than people in those other countries. So how did the richest country in the world end up with a healthcare system this broken? It didn't happen by accident. It happened decision by decision, decade by decade. And to understand where it all started, we have to go back to World War II, and a loophole that nobody ever planned to use. It's 1942. America is in the middle of the war. Factories are running around the clock. Workers are scarce. And every employer in the country is desperate to hire more people. The problem is, President Roosevelt had just frozen wages. To stop inflation from spiraling out of control, the same inflation that had wrecked Germany after World War I and helped bring Hitler to power, FDR passed the Stabilization Act, which locked wages in place. Employers couldn't offer higher salaries. They couldn't compete that way anymore. So they found a loophole. Health insurance. Benefits weren't covered under the wage freeze. So instead of offering more money, employers started offering health coverage. And the federal government, almost by accident, made this even more attractive in 1943, when the War Labor Board ruled that employer contributions to health insurance didn't count as wages, which meant they weren't taxed. Suddenly, offering health benefits was one of the cheapest and most powerful ways to attract workers. Employers jumped at it. Before the war, most Americans simply paid for healthcare out of pocket. By 1945, millions had employer-sponsored insurance. Blue Cross enrollment alone tripled in 5 years. And by the 1950s, when the IRS started questioning whether those tax exemptions should continue, the Eisenhower administration stepped in and made them permanent. The system was locked in. Here's why that matters. No other wealthy country built their healthcare system this way. Countries like Germany, France, the UK, they built systems where the government negotiated prices, covered everyone, and kept costs from spiraling. The US built a system by accident, during a war, to solve a completely different problem. And then it never went back. That original design choice, tying health insurance to your job, created a problem that we're still paying for today. Because when your employer picks your insurance, you don't pick it. You don't shop around. You don't compare prices. You just take what you're given. And once that became normal, the stage was set for the next layer of dysfunction to move in. And what moved in was not pretty. Here's a number that should stop you cold. Americans spend $496 billion every year just on paperwork. Not on doctors. Not on medicine. Not on actually treating sick people. On billing. On insurance forms. On the army of administrators that hospitals and clinics have to hire just to navigate the maze of different insurance plans, codes, prior authorizations, and appeals. Administrative costs alone now account for more than 40% of total hospital expenses. Here's how it works in every other wealthy country. the government negotiates one set of prices and pays them. Simple. In the US, every insurance company negotiates its own secret rates with every hospital, every clinic, every drug company. Each deal is different. Each plan has different rules about what's covered, what needs approval, and what they'll outright refuse. Hospitals need entire departments just to figure out who's paying for what. And that's before we even get to the denials. The national average claim denial rate in the US is around 16%. At some insurers, it's much higher. A Senate investigation found that United Healthcare's denial rate for post-acute care nearly doubled between 2020 and 2022, jumping from about 11% to almost 23%. And the way those denials work matters. Insurers use a process called prior authorization, where your doctor decides you need a treatment, but before anything happens, the insurance company has to say yes. That sounds reasonable on paper. In practice, it means people waiting weeks for approvals that may never come. Doctors spending hours on hold fighting for their patients. And in some cases, people getting sicker while the paperwork moves. When Thompson was shot, the shell casing said, "Deny, delay, depose," a phrase coined by a law professor to describe how insurers avoid paying out claims. About 7 in 10 Americans surveyed after the shooting said insurance company profits and coverage denials bore at least some responsibility for what happened. That's not sympathy for a shooter. That's a country telling you something. But here's what's almost never talked about in this conversation. Even if you somehow fix the insurance problem entirely, you'd still have one of the most expensive healthcare systems on the planet. Because there's another layer underneath insurance that most people never think about, and it has to do with who owns your local hospital. If you've ever gotten a hospital bill and stared at a number that seemed completely disconnected from reality, you're not imagining things. A coronary bypass surgery in the US can cost anywhere from $44,000 to $448,000, depending on which hospital you walk into. Same surgery. Same outcome. 10 times the price difference. And the reason is simple. In most of the country, you don't have a choice about which hospital you go to. There's only one. Over the past few decades, hospitals across the US have been merging at a staggering rate. Small community hospitals get absorbed into giant health systems. Clinics get bought up. Specialty groups get consolidated. And whenever a market tips toward one dominant hospital system with no real competition, prices go up, typically between 12 and 20% higher than in markets where hospitals actually compete with each other. One study found that if you're admitted to a hospital with no nearby competitors, your bill will be about $1,900 higher on average than if you'd gone somewhere in a competitive market. The average hospital monopoly marks up the price of care by 300% above the Medicare rate. And unlike most industries, there's no easy way to shop around. When you're having a heart attack, you're not comparing Yelp reviews. This price gouging costs Americans an estimated $240 billion in wasteful spending every year. And because most patients have insurance, the cost gets passed on to insurers, who pass it on to employers, who pass it on to workers through higher premiums. Everyone pays. The bill just arrives in disguise. And hospitals are not the only ones playing this game. Pharmaceutical companies in the US operate by a completely different set of rules than anywhere else in the world. Rules that have made the US the most profitable drug market on the planet, while leaving Americans struggling to afford medications they can't live without. Here's a simple comparison. Humira is a drug that treats arthritis, among other things. In Iceland, it costs $822. In the United States, the same drug costs $2,669. That's not a minor difference. That's more than 3 times the price for the exact same product. Brand-name drugs in the US cost, on average, 2.5 times more than they do in other wealthy nations. And that gap exists for one core reason. In almost every other country, the government negotiates drug prices. They look at a drug, decide what it's worth, and tell the pharmaceutical company what they'll pay. Companies can take it or leave it. In the US, pharmaceutical companies set their own prices. There is no government negotiator at the table. There is no hard ceiling. What the US has instead is a complex web of middlemen, called pharmacy benefit managers, who negotiate behind closed doors between insurers and drug companies. Those negotiations produce secret rebates and discounts that never get passed on to the patient at the pharmacy counter. The list price stays high. The rebate goes somewhere else, and the patient pays based on the list price. On top of that, pharmaceutical companies in the US spend around $5 billion a year on direct-to-consumer advertising, something that is illegal in almost every other developed country. Drug ads on TV drive people to ask their doctor for expensive brand-name medications by name, even when cheaper generics exist. And on top of advertising, the industry spends over $216 million a year lobbying Congress to make sure nothing changes. Perhaps the most uncomfortable truth here is this: the US, with less than 5% of the world's population, funds roughly 3/4 of global pharmaceutical profits. Every other wealthy country negotiates its way to a reasonable price. American patients make up the difference. They are, without knowing it, subsidizing the world's drug supply. This would be easier to stomach if Americans were getting world-class care in return. But they're not. And part of the reason why has nothing to do with money at all. It has to do with the fact that the US simply doesn't have enough doctors. Americans see a doctor about 4 times a year on average. People in other wealthy countries visit far more often. And one of the main reasons is simple: there aren't enough doctors to go around. The US has been short on physicians since at least the 1960s. The projected shortfall by the mid-2030s is anywhere between 38,000 and over 100,000 physicians, depending on which estimate you use. Some models suggest that if every American received the level of care their health conditions actually warrant, the country would be short over 200,000 doctors right now. There's a cap on the number of federally funded medical residency slots, the training positions doctors need to complete before they can practice. Congress set that cap in 1997 and has barely touched it since. In the 28 years that followed, the US population grew by nearly 80 million people. The number of training positions barely budged. You cannot become a practicing physician in the US without completing a residency. So the cap on residencies is effectively a cap on how many doctors the country can produce. Making it worse, those residency positions are concentrated in big cities. Rural areas, where about 18% of Americans live, have access to only 2% of Medicare-funded residency slots. So even when doctors are produced, they tend to end up in places that already have enough of them. The people who need care most have the least access to it. Becoming a doctor is also extraordinarily expensive. The average medical school graduate comes out with over $260,000 in debt. Some finish with $400,000. That debt pushes students toward high-paying specialties and away from primary care, which pays less but is the backbone of any functioning health system. And primary care is exactly where the shortage is most acute. What this adds up to is a system where you're paying more than anyone else in the world, and still waiting months to see someone. This feeds directly into the outcomes problem, because healthcare that's inaccessible isn't healthcare at all. And when you zoom out and look at what all of this produces, the insurance maze, the hospital monopolies, the drug prices, the doctor shortage, the picture that emerges is genuinely alarming. The US spends $14,885 per person per year on healthcare. The next closest country spends roughly half that. And what the US gets in return, compared to every other wealthy nation, is this: the shortest lives, the most chronic disease, and the most avoidable deaths. Life expectancy in the US sits at 77 years. The average for comparable wealthy nations is over 80. That's not a rounding error. The people most likely to die young are the ones who can't afford care, who got their claim denied, who live in a rural county with no hospital nearby, or who couldn't afford insulin and started rationing it. About 30% of American adults have 2 or more chronic conditions, things like diabetes, heart disease, asthma, or depression. In France, that number is 17%. In Germany, it's 20%. The US has the highest rate of avoidable deaths from conditions like diabetes, hypertensive disease, and certain cancers, meaning deaths that wouldn't have happened if people had received timely, appropriate care. Half of working-age American adults have skipped or delayed care because of cost. That's not a fringe problem. That's the mainstream experience. People putting off seeing a doctor, splitting pills to stretch a prescription, searching for coupons for insulin. And that avoidance cascades. Small treatable problems become big expensive emergencies. The cruel irony of the American system is that it's built in a way that feels like it should be working. There are brilliant doctors, cutting-edge research hospitals, pharmaceutical companies producing drugs that don't exist anywhere else yet. The US actually ranks near the top for preventive services like flu shots and mammograms. The machinery is impressive. The access to it is catastrophic. The Commonwealth Fund, which tracks these metrics globally, put it plainly, the US is failing one of its most basic obligations as a nation, to protect the health and welfare of its people. So here's where all of this lands. The American healthcare system didn't become this expensive and this broken because of one bad decision. It became this way because of dozens of decisions made over 80 years, each one building on the last. A wartime loophole that turned employers into insurance brokers. A tax exemption that locked that system in. Decades of hospital mergers that quietly eliminated competition. A pharmaceutical lobbying machine that made sure drug prices stayed untouchable. A cap on medical training that never kept pace with population growth. And an insurance industry that found ways to make money not by delivering care, but by managing the avoidance of it. Every one of those decisions had beneficiaries, companies, industries, political donors, who had every reason to keep things exactly as they were. And the people paying the price are ordinary Americans. The ones rationing insulin, waiting months for a specialist, opening an ER bill for $30,000 on a day they were already terrified. Going bankrupt not because they were irresponsible, but because they got sick. When Luigi Mangione shot Brian Thompson, the conversation that followed wasn't really about one man or one company. It was about what happens when enough people feel that a system is designed against them. That their pain is someone else's profit. That no matter how loud they speak, nothing changes. Whether it changes now is an open question. But one thing is clear, the US doesn't have the most expensive healthcare system in the world because it's the best. It has the most expensive system because the people who profit from the current arrangement have, so far, been more powerful than the people paying the bills. The gap between what Americans spend and what they get is not a mystery. It's a choice. And choices can be unmade.